Heart arrhythmias are divided into bradyarrhythmias, heart rate below 50 per minute when awake and 40 when asleep, and tachyarrhythmias, heart rate higher than 90 at rest. Sometimes bradyarrhythmias are life-threatening, therefore diagnosis and treatment are mandatorily quick. They are caused by 1. Structural heart diseases, 2. Abnormal plasma electrolytes, 3. Drugs such as adverse reaction to inotropic drugs, antiarrhythmic drugs, beta-adrenergic receptor antagonists overdose, etc. Tachyarrhythmias may be of either supraventricular, not wide QRS complex, or ventricular origin, wide QRS complex, and may share the same causes as bradyarrhythmias, plus hyperthyroidism. Even ventricular ectopic premature beats should be investigated because may trigger major life-threatening tachyarrhythmias, such as ventricular tachyarrhythmias, ventricular flutter, and ventricular fibrillation. Conversely, premature supraventricular beats are of a benign, and for how bothersome they may ever be and do not usually trigger major tachyarrhythmias, provided 1. They are not in runs, 2. Occurring in resting condition, or upon caffeine intake or tobacco and alcohol abuse, 3. Remitting under physical stress. Supraventricular tachyarrhythmias are A. Atrioventricular nodal reentry tachycardia, such as Wolff-Parkinson-White, also named ventricular pre-excitation syndrome. B. Real supraventricular tachyarrhythmias. C. Atrial flutter. D. Atrial fibrillation. The higher the ventricular rate, the more quickly they must be treated, at least by decreasing such high a heart rate and therefore preventing heart failure. 2 catheters being inserted through the femoral veins and pushed up into the right atrium sustain the interventional session. The former catheter enables to perform fluoroscopy and intracavitary ultrasound scan for the operator's anatomical viewing. The latter is steeped with electrodes, which record action potential while being swept all over the endocardium by the operator's external driving. The computer analysis of the many stored action potentials enables to map anatomically and physiologically the several structures of the right heart, namely appendage, superior cava right appendage keel, crista terminalis, coronary sinus, inferior cava vein tricuspid valve isthmus, sinoatrial node, atrioventricular node, down through the tricuspid valve to the His bundle and the ventricular endocardium. Conversely, the outlets of superior and inferior cava veins are electrically silent. By sweeping on, the computer returns to the three-dimensional plan of the right heart. The mapping of action potential of the left half of the heart is plotted either whenever the operator proceeds the catheter from the right atrium throughout the foramen valley into the left atrium under fluoroscopic and or ultrasound guiding. The electrical pathways and the speed of conduction of action potentials can be studied and mapped by the detecting electrodes whenever electrical impulses are given from upstream. By that way, abnormal circuits can be spotted and ablated by radiofrequency immediately, if needed. Throughout the whole electrophysiology session, both the cumulative amount of power given in joules and the pressure of the weight of the scanning catheter in grams must be estimated in real time in order to prevent the heart endocardium from being harmed. Atrial flutters may be caused by re-entry circuits in areas of both right and left atrium. However, the commonest circuit, namely the one spotted in the external electrocardiogram by the sawtooth negative F waves in D2, D3 and AVF leads, and positive waves in V1 lead, is caused by a counterclockwise activation circuit at the inferior cava vein tricuspid valve isthmus level. The atrial fibrillation is often caused by re-entry activation circuits around the four outlets of the pulmonary veins into the left atrium. The ventricular pre-excitation syndrome is usually caused by an abnormal shortcut pathway located next to the atrioventricular node. The patient's father died because of heart failure, having been living in atrial fibrillation for 10 years. 1 year earlier, the patient with normal plasma thyroid hormones perceived temporary palpitation and dyspnea occurrences both at rest and upon physical activity. The general practitioner supplied the patient with a one-lead electrocardiogram device for self-monitoring. He instructed her to apply it during palpitation and to share the PDF format exported electrocardiogram with him by emailing. After the first occurrence, frequent up to 10-15 per minute supraventricular premature beats and one ventricular premature beat were detected. Rather than applying a 24-hour Holter electrocardiogram monitoring device, the patient underwent one lead V2 monitoring during moderate stress test, maximum heart rate below 130 beats per minute. The supraventricular premature beats did not remit under physical stress. In another occurrence, the general practitioner succeeded in detecting atrial fibrillation by a 6-lead electrocardiogram. Thus, the main arrhythmia was a remitting and relapsing atrial fibrillation. The physical examination, including heart and lung auscultation, brought no additional clues. The heart ultrasound scan showed normal size and shape of the heart chambers, including left atrium, normal dynamics of the heart walls, no valvular defects, normal ejection fraction 62%, mild pulmonary hypertension. No metabolic risk factors for atherosclerosis such as hypercholesterolemia, hypertriglyceridemia, hyperglycemia, hyperuricemia were detected either. The displayed algorithm was put into practice. Firstly, a minimum of 40 days long steady reduction of prothrombin time down to 25-30% with vitamin K antagonists. Never did the atrial fibrillation last for so long to be necessary cardioversion. Thus, the clinical procedure shifted to the right part of the figure. The antiarrhythmic drug flecainide was given at 100 mg twice per day. Nevertheless, the atrial fibrillation relapsed. Once a transesophageal ultrasound scan made sure that no thrombus was floating in the atria, the patient underwent intracavitary radiofrequency ablation. The ablating catheter was introduced up to the right atrium and from there through the foramen ovale into the left atrium. The outlet of the four pulmonary veins were electrically connected to the atrial pathways, and therefore all the four were isolated by radiofrequency ablation. Actually, within the first quarterly from ablation, atrial fibrillation may relapse because some pathways may still be functioning before the radiofrequency scarring process is supposedly over, blanking period. Thus, the patient was dismissed with beta-adrenergic antagonists, metoprolol at 50 mg twice per day, to prevent high heart rate and heart failure in case of such atrial fibrillation would relapse. Rather than implanting a loop recorder in such a compliant patient, strict self-monitoring with the 6 standard lead electrocardiogram device was carried out for 2 years long. Although no atrial fibrillation was ever detected, premature supraventricular beats persisted with minor discomfort. Thus, flecainide was added to the metoprolol, but unsuccessfully. Conversely, anticoagulation therapy was discontinued after 6 months from ablation, since the patient had suffered no structural myocardial complications. The patient's father died because of myocardial sclerosis, heart failure, while in chronic atrial fibrillation. Over the latest quarterly, the patient underwent several occurrences of palpitations and, over the latest week, even orthopnea. He was admitted into the emergency department. Impending pulmonary edema and heart failure, atrial fibrillation at over 100 heartbeats per minute, some ventricular premature heartbeats, mild hypertension, 170-100, were detected. Moreover, the heart ultrasound scan showed 1. Dilatation of the 4 heart chambers. The left atrium was 65 milliliters square meter of body surface. 2. Hypokinesia of the walls of the left ventricle with 45% of ejection fraction. 3. Moderate mitral valve regurgitation. Heart failure was up and treated with diuretic drugs, angiotensin II receptor antagonists and amlodipine as vasodilators, and 2.5 mg per day of the beta-adrenergic antagonist bisoprolol, which reduced the heart rate to 80-85 per minute by increasing the lasting of the refractory period of the atrioventricular node. Such heart rate reduction enabled a better refilling of both ventricles. In the meantime, dabigatran anticoagulant was permanent given. The heart failure remitted in a few days. The volume of the left atrium and the end diastolic volume of the left ventricle decreased, and the ejection fraction recovered to normal range, although some mitral regurgitation was still present. After 40 days, the atrial fibrillation persisting, the transesophageal echocardiography ruled out the presence of atrial thrombi, and therefore the patient underwent external cardioversion safely. No thromboembolism occurred, but unfortunately no success was fulfilled either, because atrial fibrillation relapsed in just 3 days' time. Amiodarone was not prescribed because contraindicated by previous thyroid disease. The radiofrequency ablation was supported by 3 facts. 1. Heart failure recovered. 2. Volumes of the heart chambers decreased and ejection fraction back to normal. 3. No atherosclerosis risk factors. Normal low-density lipoprotein cholesterol, no smoker, no hypertriglyceridemia, no diabetes, no overweight. In the intracavitary electrophysiological investigation, the outlets of the 4 pulmonary veins into the left atrium were electrically connected to the rest of the atrial myocardial cells and were keeping up the atrial fibrillation. Such connections were interrupted by radiofrequency ablation. Thereafter, the sinus rhythm was restored by external cardioversion. The patient was dismissed from the hospital with 2 prescriptions. 1. The beta-adrenergic antagonist sotalol in order to prevent high heart rate in case of relapsing atrial fibrillation in the blanking period. And 2. Dabigatran as a permanent anticoagulant therapy according to the international guidelines for that age. Unfortunately, around 20 days past the ablation, in the blanking period, the atrial fibrillation relapsed. Within 2 days' time, the sinus rhythm was restored again by external cardioversion. From then on, the patient monitored himself with a portable 6-lead electrocardiogram device. The dose of the sotalol was established to 80 milligrams twice per day. Without discontinuing sotalol, the patient underwent moderate stress test by indoor cycling. He attained a maximum of 113 heart rate and 6 kilocalories of consumption per minute under full aerobiotic conditions, oximetry over 95%. At the peak of the exertion, the heart wall's dynamics was normal in both 4 and 2 chambers views of the heart ultrasound scan, echobike test. Ectopic premature beats occurred neither during the stress test nor in recovery. A plan of progressive increase of workload was fixed. 6 months later, the patient perceived nocturnal palpitation, and the electrocardiogram self-monitoring showed atrial fibrillation of mean heart rate of 95 per minute. Sotalol was increased to 80 milligrams twice per day, and that was enough to restore sinus rhythm in just few hours' time. Intracavitary electrophysiology studies and radiofrequency ablation of short-circling re-entry pathways, which keep up atrial fibrillation, is a safe procedure. The long-term ineffectiveness of some antiarrhythmic drugs and their adverse reactions, including both QT interval prolongation and conduction blocks, suggest to extend such therapeutical maneuver to elderly patients and therefore curb myocardial deterioration. But this recommendation is applicable whenever the myocardium is mechanically effective. No structural valvular defects are present and risk factors for atherosclerosis under control.